And next lecture is drugs in cardiopulmonary resuscitation. Definitely you need to know your drugs. You really need to know your drugs. And this is the objective. You have to know your, not just your drugs, the major actions and at least 2 side effects. Where can you see this? Mainly in your emergency trolley. Okay, so what are the routes of drug administrations? Of course, IV commonly, peripheral or central. Okay, so your central mainly for your vasopressors and inotropes. And there's a little bit of vasopressor and inotropes. Vasopressor means your noradrenaline and your vasopressin. Inotropes is your dopamine and DOPAMINE. So when you read, if they write there vasopressors, they mean noradrenaline. If it's written there inotropes, it's either dopamine or vitamin. Okay, if you can't get intravenous, you can give intraosseous, even in adult. Okay. If patient is intubated, you did not have lines, and then you can give to via intratracheal. Okay. So ideally, your IV line should be at the upper extremities and should be better if you can get a large bowel granula. And after the administration of the drug, followed by a bolus 20 to 30 ml of normal saline. Okay. Just a special thing about adenosine is you elevate the arm. Alright. So in endotracheal drug administration, you need to dilute the drug, and the dosage is 2 to 2.5 of recommended IV dose. Okay, so it's not your 1 milligram of adrenaline. You might need to give 2 milligram, but within 10 minutes of saline. Okay. Remember, administration of drugs through ETT only if you fail to get the peripheral lines and your intraosseous. Okay. If not, please use the other one. Okay. Intraosseous is not a mainstay at our hospital because we use ultrasound to get the IV lines. Okay, so this is a must-know drug adrenaline, and in fact for houseman this is your soalan bocor kan, for your first assessment. Okay, so here are the answers for your first assessment, and these are the indications basically in cardiac arrest. How you give a rapid push. Okay, 1 milligram every 3 to 5 minutes. You also can give infusion, but not during resuscitation. In resuscitation, it's all about bolus. Okay, and via ETT is 2 to 2.5 times more. Okay, so logically, your adrenaline increase your contractility, increase your SA and AV conductions, increase the systemic vascular resistance, but remember that it might cause tachyarrhythmia. So one thing you need to remember is don't give IV rapid bolus of adrenaline in a patient with pulse in any condition. Not IV rapid bolus. You might give IV dilution, as in infusions like your inotropes. Okay, but do not give IV adrenaline bolus in somebody with pulse. Okay, because of this side effect. Okay, vasopressin. I think only few hospitals are using it, maybe IGN, HKL. One good thing about this, you only give it once. So once you have given it, you don't have to repeat it as the adrenaline. But the effect is as adrenaline. Okay, so it is an alternative to adrenaline. So it replaces the first and the second dose of adrenaline. Okay, is it in your? It's been mentioned. It will be mentioned in your MCQ. Okay, next is your atropine. Atropine, as you know, is your medication for unstable bradycardia. Okay, unstable bradycardia. Okay, you can give IV 0.5 milligram and via ATT again 2 to 2.5 or up to 3 milligram and dilutes in 10 ml saline. And these are the side effects of atropine. Okay, once you give atropine, the pupils will be dilated. Okay, so don't take it as poor prognosis. Okay, it's because of your atropine. Let's say patient is bradycardic, you give atropine and then patient complain to you, doctor, I am blurring of vision. Then you look at the pupil is dilated bilaterally, then you ask for CT brain. It's ridiculous. Okay, you might laugh, but you might answer that in your answering sheet. Okay, amiodarone. Okay, amiodarone is special because basically it can cover almost all the arrhythmia. Okay, so the administration, there's two ways of administration. And one is for cardiac arrest. Okay, remember if cardiac arrest is your 300 milligram bolus within 1 to 2 minutes after your third shot. And 150 milligram slow bolus 1 to 2 minutes after the fourth shot. Okay, that's the only when we give bolus. Okay, in a stable arrhythmia, if you use amiodarone, you give 150 milligram over 10 minutes. Then within 10 minutes, you look whether the tachyarrhythmia improve or not. If it's not improved, then you can add on another 150 milligram over 10 minutes, followed by 900 milligram over 23 hours. But if you, well, majority of you like to use the Sarawak protocol. Sarawak protocol stated that if you give 300 milligram over half an hour. Okay, but if you think logically, if 150 milligram over 10 minutes, the tachyarrhythmia subside or resolve, why you need higher dose? Because amiodarone is not without complication. Okay, even now recommended amiodarone is 150 milligram over 10 minutes. Okay, lignocaine. Sometimes your verapamil fail, your adenosine fail. We have lignocaine, okay, as anti-arrhythmic, especially if patient have allergic to amiodarone. Because usually we will use amiodarone, but if patient known to have allergic, meaning this is his or her third or fourth admission, before this, after giving amiodarone, then develop itchiness, shortness of breath, and then please do not use amiodarone. So we go to lignocaine. Okay, lignocaine. This is the dose. 1 to 1.5 milligram per kilo. Additional is 0.5 to 0.75 milligram per kilo, and maximum is 3 milligram per kilo. And you can also use it as infusion. Okay, let's say in your MCQ tomorrow, if the question came out, what is the second dose of lidocaine? I mean, you give the first dose of lidocaine, failed, patient still having tachyarrhythmia, what is your second dose? So this is the answer lah. Okay, you got me? Okay, so basically half the dose lah. Right. These are the side effects of lignocaine. It can cause seizures, respiratory depression, widening of QRS complex, and cause bradycardia. Okay, adenosine. Adenosine mainly used in SVT after failed the vagal maneuvers. Your thoracic massage fail, your vagal maneuver fail, then this is your first line adenosine. But again, what good about adenosine? It is rapid, so you can see the effect immediately. But you have to counsel the patient, because patient might feel heartburn, flushes, breathe on the chest, chest pain, and the most scariest thing is initially patient listen to the cardiac monitor kan, tit, 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 and then you administer adenosine. What happened? Tit, 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 tit. Then patient looking at you, you are looking at the patient. You have to tell the patient, Encik, when we administer adenosine, your heart rate will slow down, but don't worry, we are around to help you. Okay, so you have to get basic consent. And special about adenosine is you give it rapid push. You give adenosine followed by 10 to 20 cc syringe of saline, and then you elevate. So you can ask the patient, whether patient have experience with adenosine before. Encik, before this, when we give medication, is there anybody pull up your arm? Oh yes, there's somebody. Yeah, I have 2 or 3 instances. So meaning that this patient have recurrent visit to ED for SVT. But again, you can use 6, 12, 12. The first dose is 6 mg. It failed, then 12, then the third dose is 12 mg. And if failed, then you have to convert to verapamil, or next is your famous AMIODARONE. Alright? Okay, so basically these are the side effects which we need to tell the patient. Okay, transient bradycardia, because patients who are alert will easily get panic when they listen their heartbeat and becoming less and suddenly stop. Okay, so dopamine, as you know, is your anatropes used in your shock, and basically you need to give it through central vein. Means you need to put in your CVP. But let's say if you are working in the district, you don't have CVP, you can put it at the patient's femoral line, femoral vein, okay, or the neck vein, or which one is the largest vein possible. Okay, this is a dose, and of course, the effect will increase the BP and also will increase the heart rate. Okay, so be careful with that, because it can cause, dopamine itself can cause tachyarrhythmia. Examples, patient post-MI, okay, with cardiogenic shock. After you have thrombolized the patient, you have strapped the patient, BP low, you start dopamine. Initially patient chest pain also have improved, then patient become tachycardic, and then he complain about chest pain. Okay, because of the tachyarrhythmia. When the heart beating faster, your coronary filling will be less, so less blood supply to the heart. That's cause the chest pain. Okay, sodium bicarb. Okay, sodium bicarb will be given in patient with acidosis. Remember, you always ask for ABG and VBG to look for the reversible causes. Okay, so please use a special line. We don't want it to be injected at the same line with your inotropes, okay, and your calcium. So what is the dose? What is the dose? Yeah, milli-equivalent per kg. So if a patient is 50 kilo, then you can give 50 equals to 15 mils. Okay. So in resuscitation, you run it faster. Normally we give about 30 minutes to 1 hour. But during resuscitation, you can give it faster, within 10 to 20 minutes. Because if you give it longer time, patient already we already cakap patient have no life, but the bicarb is still ongoing. Okay, so that's why in resuscitation we administer it a little bit faster, 10 to 20 minutes. Okay, let's talk about your lactic cocktail. Okay, so far you are lucky because when you say lactic cocktail, the nurse understand it. But sometimes you don't have the privilege to work with senior paramedic. Sometimes you work with junior paramedic who is first day of life. So you ask for lactic cocktail, and she will go to the nearest bar and bring you the cocktail. Okay, so what is your lactic cocktail?
50 cc.
Okay, use calcium first. Okay, so how much is your calcium?
10
Okay, 10 mils. Okay, slow. So you give slow bolus followed by okay, D50 50 cc and your insulin, your ATROPINE. How you give your insulin? IV, intravenous. Because remember in resuscitation we want everything to be fast. So not subcut but your IV. Okay, then you will see improvement if the potassium improves. Okay, good. Any drug we miss out? Magnesium sulfate. Okay, why is that? Why you ask for magnesium? Okay. Okay, total DIPWA. Magnesium sulfate is the first line treatment. So total DIPWA is a little bit special because in the algorithm, once you diagnose patient have total DIPWA, you need to administer magnesium sulfate.